Welcome to the CARE Coordination Learning and Action Network conference call. My name is Nathan, and I will be your operator for today's call. At this time, all participants are in a listen-only mode. Please note that this conference is being recorded. I will now turn the call over to Sally May. Sally, you may begin.
Thank you, Nathan. Good afternoon, everyone. As Nathan said, my name is Sally May, and I will be hosting today's webinar. On behalf of the Great Plains Quality Innovation Network representing Kansas, Nebraska, North Dakota, and South Dakota, I want to welcome you to today's webinar. As much time as will allow, we will have a question and answer session at the conclusion of the four presentations, but we encourage you to submit your questions throughout the presentation using chat, which will be monitored by my colleague, Vanessa Lamoureux. To open chat, please click on the chat box in the top menu of the WebEx event during our webinar. If your questions are not answered during our webinar, we will provide the answers along with a copy of today's slides and recording on the GP QIN website within a couple of weeks. Let's quickly review the four considerations to improve health and well-being developed by CDC and partners. Starting at the top left corner of the slide, chronic disease is complex. There are multiple contributing factors, including the socioeconomic diseases, the physical environment. In fact, are there sidewalks for walking when we're telling our clients or our patients they should be walking more? Also, a factor is individual's health behaviors, in other words, his or her lifestyle choices. And last but not least, is the clinical care that individuals with a chronic disease receive. The prevalence of chronic diseases is not consistent across states, counties, or even zip codes. What do you know about the geographic prevalence of chronic diseases in your community and the reason for this? Chronic disease management requires all hands on deck. No one healthcare setting, no one organization will be successful if they're attempting to do this independently. A community-balanced approach includes evidence-based clinical care, access to chronic disease self-management, educational opportunities to address the health behaviors. And though addressing the physical environment and socioeconomic factors are longer-range interventions, they are no less important. On today's call, you will hear from four different communities and their four different stories of how they have addressed chronic disease in their communities. We framed today's webinar around four questions from the Plan, Do, Study cycle, also known as the PDSA cycle. I encourage you to listen carefully to how these questions are addressed by the different communities. What exactly are we going to do? When and how did we do it? What were the results? And what changes are we going to make based on our findings? I would like to introduce Debbie Swanson, Director of the Grand Forks, North Dakota Public Health Department. Debbie, how did the Grand Forks community answer? What exactly are we going to do?
Thank you, Sally, and good afternoon, everyone. It's a pleasure to be here and tell you a little bit about our story, which begins far before the management of chronic diseases, but really with an assessment process. And what I want to highlight today is really the collaborative effort of this particular process and what we learned in it and how it will lead us to improving health in our community. So it might be a little bit of a different twist on the other presenters' presentations and what you may have heard before, but I hope that there's some useful information for you as you plan how to approach chronic disease management in your communities. Next slide, please. In the city of Grand Forks, North Dakota, we have a health department that encompasses the entire county of Grand Forks. And we are required to conduct a community health assessment for public health accreditation. And our partnering hospital, which is Altru Health System, is also required to conduct a community assessment as a requirement of the Affordable Care Act because they are a community benefit hospital. So what we decided to do was join together our efforts and involve sectors in our community to conduct this community assessment. We expected that everyone would share a common agenda to improve health, and thus we selected our partners based on that goal. Next slide, please. We are fortunate that in our community we have strong collaboration, and that's evidenced by a number of partnerships and coalitions that we've had in our community for a number of years. They include things like a dental coalition, which was successful in establishing a public health dental clinic in our community, a healthcare alliance, which established an F2HC in the area. Permanent supportive housing is something that we're currently working on, and although the health department doesn't lead it, we're involved in that effort. There's a rural care transitions group, and of course emerging as it is in many communities, a committee to address opioid abuse in our region. We also are a resettlement community for refugees, so we've had a long-standing effort around refugee integration with good collaboration, and our health department has led a tobacco coalition for almost 20 years now. There are other efforts as well, but I think we really benefit from the fact that we have this long-standing history of coming together to address community issues and community health issues. And so there are many benefits to those partnerships when looking to achieve our goals, and one of them is the ability to share data and resources. When you bring so many partners together to the table, everyone comes with their own set of resources that they have available to them, and they're very willing to share their data in most cases. I think one of the other benefits of these partnerships and collaboration has been that groups have capitalized on opportunities to improve health with some unique side partnerships. And also the results of our community health assessment, when it was conducted 3 years ago, or 4 years ago now in 2013, many agencies were able to use that information to write grants and advance the work that they were already involved in. Next slide, please. This is a list of all of the agencies that were involved in our community health assessment. We formed an advisory committee, and we had at least one representative from each one of these organizations. I wouldn't say that it's entirely comprehensive of what a community health assessment should be, but we had strong participation from each one of these agencies. You can always add more partners to the table, but this was a good working group for us. We think that it is very broad in terms of its membership, and we think that all of the partners brought to the table a number of really good resources. And if you look at that very first slide that Sally presented to us, we really were looking to address the socioeconomic factors as well as the physical environment, health behaviors, and lastly, clinical care. So we looked at doing our assessment from a framework that was very similar to that. Next slide, please. The elements of this community health assessment included community health data, so what was available to us from a variety of sources, including national sources, regional sources, statewide, and county level. We tried to get our data as close to our census tracts as was possible within a two-county area. We also conducted community surveys with our residents. We had about 400 participants in that. And then conducted focus groups, including some hard-to-reach populations. Those included people with disabilities, seniors, our new American population, and people who were homeless or experiencing homelessness. So we felt like we really went deep into the community to find out what people thought about health and health factors in the community. And I would emphasize that these first three elements of the assessment were largely conducted by Master of Public Health students from the University of North Dakota with advice from our advisory committee and participation from the lead agencies, which was the health system and the public health department. And then following the presentation of all this information to our advisory committee, we looked at a number of priority areas and then honed it down to just 5 that we wanted to work on for the next 3 years. And most importantly, we communicated those results to the community and to our stakeholders. We conducted meetings at board meetings for the hospital, at our Board of Health. We published the information in the newspaper and tried to get it out as broadly as we could, including the websites of all of our organizations. Next slide, please. So in case you're curious, These are the priority areas that we decided on based on some criteria that we set in terms of things like how prevalent was the problem, what was the impact, what was the sense of urgency around it. And a couple of these areas did appear in a community health assessment as a priority 4 years ago, but there are some new ones. And so the priority areas were improving access to behavioral health, including addiction treatment and counseling, reducing the incidence of prescription and illegal drug abuse, and that's certainly a problem that many of you are aware of or working on in your communities as well. That was a new one for us. And reducing the rate of obesity, which was one that was carried over. Reducing the incidence of binge drinking and alcohol abuse, that's also one that was a carryover from a prior assessment. But another new one was improving care coordination and access to health care. So we did end up having a lot of discussion about care coordination and how clients access services now that we had some new players in the community with an FQHC. And we had people who had never before had health care insurance but now had coverage, and so they needed to learn how to use the health care system. So we have a strong emphasis on that care coordination piece moving forward. Next slide, please. We are now working on a community health improvement plan, and this element of our next steps started with self-selected and invited participants, people who really wanted to dive into that data, the priority areas, and look at some goals and objectives for the next 3 years. And we feel that this having self-selected and invited participants really encourages buy-in from the partners. There's a strong focus on detailed planning to improve health, and a recognition of existing efforts in the community. We certainly didn't want to dismiss any of the great work that had been going on already. And it really promotes evidence-based strategies. With limited resources, we really have to make sure that we're only using those interventions that are going to get us the most bang for our buck and really are supported in the evidence. And it encourages engagement of policymakers. How can we have strong policies that will improve health? And taking that message to our policymakers has also been an emphasis. It creates a call to action for the entire community as well. And throughout this process, we've been really pleased that we've had great attendance at all of our meetings. We've had good engagement and really a willingness to work together and a spirit of collaboration through it all. That's not to say it hasn't been without its challenges, but we certainly think that we're in a much better place because of this collaborative effort. That concludes my presentation, but of course I'll be on through the end of the webinar and available to answer any questions. I did want to provide my contact information so that if anyone had questions about this process, that you could certainly contact me at my email address or telephone number there. Also, our website is listed, and you can go there to see our community health assessment results. Thank you.
Thank you, Debbie, for sharing the Grand Forks community story. There's a lot we can learn from your story. Our next community, the question we ask them is when and how did we do it, or how are you doing it? I'd like to introduce Deb Williams from the Labette Center for Mental Health Services.
Thank you, and good morning to everyone. Labette Center is actually in the southeast Kansas corner of Kansas in a town called Parsons. About 20,000 people in the county. So we were really looking for something to help our folks in our county. Next slide, please. So what we did was there were 4 of us trained on the Stanford Self-Management Education Program. We currently offer 3 workshops, which are 6 weeks long, 2.5 hours at a time. And we offer the chronic disease, chronic pain, and the diabetes. How we got started was we reached out to the medical providers in Labette County, mental health providers, our physical and occupational therapists, community groups such as Seroptimus, Lions. We also offered our workshops to providers in neighboring communities. Next slide, please. through all this, we were able to have some great partnerships. Labette Health physicians, Labette Center for Mental Health clinicians, our senior centers, the Physical Rehabilitation Center, area mental health centers in other counties, and medical departments within Labette Health. All of these partners needed to really understand what the workshops involved and what they were about. So we invited our partners to come sit in on a workshop day and just see what it's really like. There were too many that were unable to come, so we just went to them and said, okay, ask us your questions. What would you like to know? And we were able to show them and give them the information that they needed so that they started to really refer folks to our workshop. Next slide, please. Of course, there's always obstacles that we all have to overcome. One was some other education services that were doing workshops saw us as competition. There's no public transportation in rural southeast Kansas for our participants. We had to look at the timing of our workshops. And we also had to find a place for the workshops to be held where everyone that wanted to participate would be able to find us. Next slide, please. So we were all about, let's conquer these little obstacles. So flexibility. We had to be flexible in the day, the time of the workshop. We had to somehow offer transportation. Well, in Parsons, one of the developmentally disabled groups here has they offer transportation to and from appointments, but you had to have tickets, which cost money. So we went to the mental health center and said, can you provide us with some tickets for some participants, which they did. So we were able to then offer these participants the transportation that they needed to come to our workshops. We had a simple referral form. The Kansas Foundation for Medical Care on their website has an RX referral form, and the doctors seemed to really like it. It was very simple, with just the name, phone number, how to get a hold of the person, and that way we were able to contact all of our potential participants. As soon as we got that referral, we were calling them, sending them information, making sure they knew how to get to us, that they had a ride or had their own transportation, and if not, then we got those participants' tickets. Next slide, please. Our participants were very successful. We've been very lucky in having participants that really came and really wanted to learn from the group leaders, but also from each other. And their successes are that they're able to communicate with their medical providers. They don't go in and just sit and expect that the doctor's going to just tell them everything and they're not going to be able to ask any questions. They have now the appropriate use of the emergency department. They're building relationships between the participants, not involving the group leaders. They get together outside of the workshops to talk about what they've learned, what questions they have. Maybe somebody else has an answer that might work for them. They also, during the workshop, is very interactive. So they work together to problem solve or brainstorm for each other. The most important thing was that they saw that they were not alone in their battle with their chronic condition. Next slide, please. So our program successes include word of mouth. This is participants talking to other folks that they think could benefit. It's going back to their physician and saying, you know what, I took that workshop and you would not believe all the things that I learned. So that the physicians are saying, okay, this is really a helpful workshop for me to send my other patients. We have referrals as a culture change. That happened at the hospital. They now see the workshops as something that they want their patients to participate in. We also have the successes of the participants. They are very vocal, and they tell us what they liked, what they didn't like, what maybe we could help them change about the workshop by going through Stanford. And then we have the successes of the group leaders. The group leaders not only were leading the group, but they were also participating. And so they felt like they've learned about chronic conditions, they've learned about themselves, and they've also learned some new tools from the toolbox that you get in the workshop for their own lives. Next slide, please. So if anybody has any questions or anything, I'm more than willing to talk with you. Here's my information. Please feel free to give me a call. Thank you.
Thank you, Deb, for sharing your community's creative approach to improve individuals' chronic disease management. And continuing on, now to answer the question, well, what were the results, and address the value of data, I want to introduce Melissa Gale from Avera St. Benedict Health Center in Parkson, South Dakota. Melissa, the floor is yours.
Thank you. This is Melissa Gale from Avera St. Benedict Health Center, and that is located in Parkson, South Dakota, which is in southeastern South Dakota. It's a community of about 1,500 people, and we have a clinic, critical access hospital, and then 2 other outreach clinics within our service area, which is a pretty large service area in southeastern South Dakota. Next slide, please. So when we took a look at quality from the clinical level, we wanted to look at what quality really meant to us. We knew what quality meant in terms of the national picture, but we wanted to make it apply to us. So we took on a new view of clinic quality. So the first thing we did was to set up a quality infrastructure, which included a team. It included myself in clinic quality and behavioral health, and a person that was very good with running our electronic medical record and accessing reports and data, our CFO, our clinic business office manager, and then we also have every provider, their nurses, and our front desk staff rotate through each month, so we have a fresh perspective on quality and have everyone's input at the table. So we wanted to look at quality from the view of that we knew we provided great quality of care, and we wanted to be able to prove that through our numbers to make our facilities successful. So some of the initial things that we heard were, all I have to do is click this button. I've never clicked that before. How many clicks it takes to do that? So we started to reframe to focus on quality and focus on specific measures. So at the beginning, we focused on the ABCSs for a million hearts, which is aspirin, blood pressure control, cholesterol management, and smoking cessation, and also focused on our PQRS measures, which were basically the same with a couple additional ones added. Next slide, please. So when we started looking at our data, our first initial gut reaction was, this data is wrong. We know we provide great care, and our numbers don't look so good right now. So then we started trying to break through the data. So we worked very hard to validate the data, to see where the data was coming from, to use transparency, meaning everyone seeing everyone else's PQRS numbers. We posted them in the clinic. We brought them to med staff meetings. We started getting all employees just on board with knowing what data looked like, not to downgrade anyone's performance, but also to promote some healthy competition, because everyone in the healthcare industry likes to do well. Everyone wants to do well by their patients. So we try to invoke the competitor in all of us to do well. And we just started reframing the purpose of the data, that we wanted to drill the data down and fix the processes that was driving data either in a negative way or a positive way, and to isolate any recurrent issues for training purposes. And we found out right away that not everyone speaks data, so to speak. So we addressed those things as it came along and spent a lot of time one-on-one with providers, nurses, just making sure that everyone knew exactly what the data meant. Next slide, please. And we started to find out, after we started working on the data and making it legitimate for us, that a lot of workflows needed changed. So we started by changing some workflows at the front desk where people checked in and registered. We also went through the workflows of rooming patients, and we started to standardize things where we could, and we started to get control of the things that we literally could control. So we can't always control what a patient does outside of the walls, but we can control that protocols are practiced the same way. And we kept the communication open all the time between the providers through our monthly groups and daily check-ins, and just made sure that everyone felt like it was an environment where they could communicate concerns or ideas. And then we started mapping where the data comes from. If we pulled a report, we could then look back and say, oh, this is the reason. It's not that the person didn't do this, it's that they put it in the wrong spot in the medical record. So we were able to start teaching people, this is all you have to do to make your numbers get better. You just have to click here instead of here, or you have to put it in a data field instead of typing it or dictating it in some cases. So we did that and worked on following patients all the way through the facility from when they walked into the front door, through nursing, through providers, through the clinic billing and coding, and out the door. So we knew exactly what was happening with all the patient's information all the way through their process. Next slide. So then we started to operationalize the data and specifically work very hard on our blood pressure control, because that was one of the measures not just for Million Hearts that we were working on, but also for our PQRS. So we got our baseline data, and when we first started this, our baseline data for hypertension control was 16%. So we knew that there was problems, and we knew that our numbers were better than that. We just needed to make some changes. So we started standardizing and educating on how to take a blood pressure. Not that our nurses didn't know that, but just reminders. You know what, when the person just walks down the hallway, let them sit for a minute. Just simple things like that, so everyone was doing it in a standard way. And then we found out that our automatic blood pressure cuffs, our vitals machines, seemed to be high when taking blood pressure, so we did a side-by-side manual versus auto blood pressure study and decided that we needed to look at getting our auto machines recalibrated. And then we got some new tools for the nurses so they had the best equipment to use for the best quality. And then continued to tweak workflows such as adding a second set of vitals, taking a blood pressure at the end of their clinic appointments, and also using some visual cues to remind them or to communicate with the provider if it was high and they were maybe rooming another patient and couldn't get back to tell the doc that right away. So we continued to monitor these through our data and then through just random chart audits, and just worked on troubleshooting from the numbers perspective and how that would drive our workflows through monthly data checks and a lot of daily auditing as well. So then we started to trend the data over time to see what changes we made in the workflows and how that affected our data. So then as of up to today, today our post data shows that our blood pressure control is over 70% now. Next slide. So I think I had a couple more slides, but the next one I was just going to talk about briefly was my contact information, so I can be contacted at my email, which is on the first slide.
Yeah, we'll make sure that gets sent out when it's up.
Thank you.
Thank you, Melissa. This is just such a powerful story about how to not only capture data, but how to utilize that data and how you make changes based on that data. Thank you very much for sharing your story, which I'm sure is an ongoing story. Our next community is going to address the question, what changes are we going to make based on our findings? So I'd like to welcome Brenda Bergman Evans. And Brenda?
Good afternoon. Do you have the slides up? Good afternoon. I'm Brenda Bergman Evans and have had the pleasure of being the project director for a CMS-funded grant to prevent avoidable hospitalizations for long-term care patients in 14 facilities within a 25-mile radius of Omaha, Nebraska. Our group has been working in long-term care and skills since 2005 and have recognized that dental and oral care has a significant effect on health and chronic disease, but often does not get as much attention as is needed. Certainly, referring back to the Invest in Our Community slide from the beginning of this webcast, it can help us understand some of the reasons why oral care is so important and multifaceted. Socioeconomic factors play an important part of dental care, from the past dental care that the residents may have had to having the correct equipment and products beyond just a toothbrush that they need now. Physical environment, often folks are in a shared bathrooms or rooms. Health behaviors, even if the individual has always brushed their teeth in the past, now are they able to complete that task independently? And clinical care, attention to the effect that oral care has on chronic disease outcomes. Next slide. Poor oral care has been associated with both the onset and control of chronic diseases, especially heart disease and diabetes. By affecting good nutrition, additional maladies such as vitamin deficiencies and anemias can occur with poor dental care. Also, inadequate dental care is associated with acute conditions such as pneumonia. Next slide. A healthy mouth helps people to eat well, to smile, and to interact confidently with others. One of the banners on a dental advertisement was, "How can you eat when you have no teeth?" The short answer is that store-bought teeth will never work as well as the original, especially if they no longer fit or slip. Often we find the dentures in the napkin beside the plate as the resident eats, and occasionally they mistakenly may find their way to the trash. Also, the poor-fitting dentures may limit food choices and can lead to embarrassment. Next slide. Helen Keller said that I long to accomplish a noble task, but that it's my chief duty to accomplish small tasks as if they were great and noble. This could have been a slogan for our interest in work with oral care in long-term care. By concentrating on the pillars of assessment, prophylaxis, and education, we focused first on qualitative data and clinical care, and also realized the importance of qualitative measures and outcomes, such as quality of life issues. I suspect that if we poll the people on the call today, that most include in their morning and night routine brushing and flossing their teeth. One of the simple pleasures in life is having a clean mouth before we sleep and when we rise. To paraphrase Yoko Ono, smile in the mirror, do that every morning and every night, and you will start to see a big difference in your life. We would add right after brushing your teeth. Next slide. Our CMS Enhanced Care and Coordination Grant had two arms. One focused on care by nurse practitioners with medication and management of disease to avoid hospitalizations. The other was on dental care to help in the same areas. We had 2 dental hygienists and a consulting dentist from the Creighton University. Next slide. This is the volume of work that was done through May of 2016. In the second year of the grant, we recognized the importance of the work and added a second dental hygienist. Interestingly, we had estimated from the literature that about 50% of the participants would be a dentist over the course of the grant. We did see the percentage of folks with some teeth increase, albeit many of the times the teeth were in for repair, but they did trend up. This really challenged us as we look to the future because that is going to be more of a focus for our long-term care for patients. The referrals to the dentist included broken teeth, oral lesions, and the need for fillings. The increased number of pneumonia patients may be more related to the close work between the 2 arms of the program and the increased treatment of recognition and treatment of pneumonias in facilities rather than hospitalization. Next slide. The strengths. Although it is an expectation of the care routine in facilities, oral care is sometimes missed as frenzied staff scurry to brush hair, change shirts, and get people to meals. In-house treatment with no transportation required. When I started in gerontological care, a wise colleague said that transportation is one of the biggest challenges. And years later, it is true whether we are in a community or in a facility. And I heard it from one of the other presenters, especially in localities where we have big rural areas. So we really need to take as much care to the resident as we can. The involvement of CNAs and RNs in the oral care and education with the emphasis on change in behavior, it helps not only the residents, but also sometimes it helps the RNs and CNAs to really take better care of their teeth as they receive this education. Another hit was the dental records for state surveyors that assured that proper dental care was provided with good documentation of the same. The increased access to dental care were otherwise not provided. Many times for folks with cognitive challenges, behaviors, or disabilities, a trip to the dentist is not even a possibility. As far as challenges, private dentists, sometimes there could be loss of income, but also the loss of long-term personal relationships, either with family or friends. Faculty facility turnover. Some facilities had more than 100% turnover on an annual basis, so the need to be like a broken record, retelling one story and gaining support for the program was ongoing. Costs for potential reimbursement. The costs are significant, and the reimbursement is low. This is further complicated by the equipment costs, both purchased and the needs for processing. You need to have an autoclave, and you need to be able to repackage and keep track of all of the equipment that is used. Patients with behavioral issues. This was one highlight, I thought, from the work that was done by the dental hygienist. We thought that there might be more people that wouldn't be able to be treated because of behavioral issues. But by and large, with tincture of time and being patient, they were able to see most everyone. And that came from being around the facilities and going to when the patient was able, or the resident was able to have the care, rather than when we were there to give it. No specific space for treatment and ergonomics is a challenge. We did have a portable chair, but it was bulky, and then there was the problem of where to store it as we stayed in facilities about a week. Lighting is unfortunately not very good in some places. They did have headlamps that helped, although sometimes they look more like coal miners than they did like dental hygienists. And beauty chairs can pitch in for a dental chair in a pinch. Next slide. Overwhelmingly, the dental arm of the program was well received from leadership, staff, families, residents, other dental professionals recognized the benefits of providing the service and education in the facility for this very high-risk population. I have a Charles Schultz penis cartoon that says, whenever anyone brings up a good idea, someone else brings up the budget. And in the current world of dwindling Medicaid support and continual challenges at all levels regarding funding of health care, providing oral care to long-term care residents will continue to need attention and support. As we always, it often takes a second seat in daily care. It has been my experience that sometimes it's been easier to receive the okay for a patient to get a pacemaker than new dentures. So we really need to focus on how we can maintain the residents' teeth that they have and keep them in good repair. This combination of services with dental hygienists partnering with care staff was successful and the right thing to do. Thank you very much. The last slide does have my contact information, and I'd be glad to answer questions on this or on the other arm of our work as well. Thank you very much.
Thank you, Brenda, for sharing that very creative approach to providing dental care to residents who otherwise would be lacking that care. I think it looks like we have several minutes for questions that you may have for our speakers regarding their unique community intervention addressing chronic disease management. You can use *mute to unmute your phone line. And while we wait for any questions coming from the phone, Vanessa, what are you seeing in chat?
Well, we actually have a question in the chat, and the question is for Brenda. And the question is, will the addition of another member of a dental team, such as a dental therapist, be a benefit to this great program?
No, I think that is a good question, because one of the things is that we recognize residents receive dental cleaning twice a year, the prophylaxis twice a year. But it's so important to have someone that's a champion in the facilities really working at that daily oral care. So I think that would be whether it's a champion or another member, that would be a big help.
Thank you, Brenda. Are there any other questions, Vanessa?
No, there are no other questions at this time in chat, but I just want to say that it's been great to hear from these different communities who are very unique, and the interesting approaches that each of them are taking to chronic care management in ways that might be a little bit out of the box for some of us. So I just want to encourage those that are listening to go ahead and chat in their question, or to use the open phone lines using *2. And we just got another one in chat, and it's for Melissa. Melissa, did you see a change in clinical staff processes?
Absolutely. We have pretty much turned processes upside down, so to speak. So most processes are different now, and the biggest change in a positive way is people's buy-in, and they're willing to rely on the data and understand that it's to help everyone get better to ultimately serve the patient, because that's what everyone is there for.
This is Brenda, and one thing I really thought from your presentation is that importance of calibrating for healthcare professionals to really depend on their clinical skills, but taking the blood pressures and then making sure they calibrate the equipment so that it works and is correct. So that was great.
We did also find out that some vitals machines cannot be calibrated. So just kind of a helpful hint to some people. We actually probably have better luck with manual blood pressure than the vital machines.
Yeah. And there is just such a thing about that laying on our hands for people, that connection. That's a good thing as well.
So, Melissa, this is Sally. The question I have for you is, what was the response of the patients that you were seeing, the patients and their families, when they saw this change going on in the clinic? What feedback were they giving you?
I think for most patients, they didn't even recognize any changes were going on because we implemented the changes simply and one thing at a time. So the little changes probably no one even noticed. So I don't know that it really made much of an effect on the patients noticing any of the changes at all, versus maybe they had to get a little bit more information from them when they registered, that maybe some of them might have thought it was odd that they got blood pressures retaken possibly 2 or 3 times or at a different time than right when they walked into the exam room. So honestly, I don't think that from a patient perspective it made much of a change, and most of them, I'm sure, didn't even know we were doing things differently.
Thank you. Nathan,
Sally?
Are there any questions in the queue?
We're showing none.
Okay, thank you, Nathan. All right.
So, Sally, this is Vanessa. I actually have a question for Deb and for Debbie, our two presenters that kicked it off talking about the plan and the do parts of a PDSA cycle. Both of you guys really focused on kind of the partnership aspect and the unique voices and how you can engage those folks in your community that are maybe not your common the common folks that you go to address chronic disease management. What made you go that route, and have you found that to be successful in driving change?
This is Deb. One reason we did that and we reached out to the unusual voices was mainly because if you're going to be successful, you have to reach as many people as possible. There were people in, like, the service organizations that we may not have talked to if we hadn't gone and talked to them. I've been on the radio a couple of different times here in Parsons to do just an informational little talk on the radio. So it's given us a chance to reach more people in different parts of our county.
This is Debbie, and I would add that our stakeholders brought some unique opportunities to us so that we could engage people who are actually receiving services. I think there's a tendency for all of us to think that we know what people want, but we had to be really intentional about listening to what they wanted. And so we did the focus groups, and that's where we got really, really rich information about what were some of the challenges people really were experiencing related to accessing services or having their care coordinated well. And they involve things like making sure that we had culturally appropriate interventions and interpreters, and that there was recognition of the challenges that people in poverty experience when trying to receive care, especially behavioral health care. So I think that it will help us in the long run, and I think we'll have to be really intentional, as I mentioned before, about paying attention to that information and going back to it frequently.
So, Sally, we have a follow-up question, and this one is for Deb in Kansas about how you obtained your partners. So we heard a little bit about in the presentation about reaching out to your medical community in your home-based community as well as those around you, and even just now a little bit more about the radio conversation. Can you talk a little bit more about other partnerships that you obtained and how you went about that?
One thing that we did, we spoke to as many service organizations as possible, took them information. For the Lions Club, we actually did a brainstorm so that they could see what the workshop would be like, and we had actually 4 people from the Lions Club come and take the workshop. It's just really going out, talking to people, understanding what you're selling, so to speak, and then answering the questions and offering to talk to their patients, talk to their nurses, whoever that they wanted us to speak to, we went and talked to them.
And Sally, that's the end of the questions that I have in chat right now.
Okay, thank you, Vanessa. What we've just heard are 4 stories from 4 different communities related to chronic disease and chronic disease management. And though their interventions are as unique as their communities, what we've heard in each of these stories is that they're doing this work with partners. They're not doing it independently, that it really does take a team to address chronic disease within a community. So my question for you is, what action will you take to improve chronic disease management in your community? Maybe there's one of these questions you would like to tackle. Just what exactly are we going to do about chronic disease? And you can fill in the blank about what chronic disease that is in your community. When and how will we do this? How are we going to accomplish that? What were or will be the results of that change? What do we hope to gain, and how will we measure that to know that we achieved that gain? And what changes could you make based on your findings? I encourage you at the close of this call today that you just have a conversation, particularly if you're listening to this call with other folks in the room. So leading in action, I've challenged you with 4 questions. I'd also encourage you to check out some of the resources that we have on the Great Plains Quality Innovation website. View the latest update of our State Care Coordination and Medication Safety Quarterly Report, which is more about the outcome measures and healthcare utilization. It's available on our website as shown on the screen. Also note the various chronic disease management resources that are available on our website. You can also receive assistance with your plan to improve chronic disease in your community during our April coaching calls. One of the messages we have heard again and again from communities is that you want a platform to learn from each other. In April, we will have another opportunity to do just that. We will be hosting 3 separate calls on April 25th from noon to 1. Each coaching call has its own call-in number. We have the medication safety call, reducing rehospitalization, and then chronic disease management. It would be a great opportunity for you to call in on that call and follow up with a question related to the presentation that you just heard this afternoon. These coaching calls are your opportunity to really virtually meet with your peers to discuss the how of a specific care coordination strategy. You will receive a reminder email in the next couple of weeks, but no registration is required. Simply call in, and you see the number there on the screen. Our next webinar will be May 23rd, and there will be more to come on that. Is there any other questions in the chat, Vanessa?
There are not any questions in the chat at this time.
Okay. Thank you, Vanessa. We are here to support you with your plan. You may contact any of us via phone or email. Thank you for joining us and our 4th guest on today's call, and thank you for the care you provide to the individuals you serve in your community. This concludes today's webinar. Thank you for joining.
Thank you.
Thank you, ladies and gentlemen. This concludes today's conference. Thank you for participating.